Great. So, as you see, the topic of my presentation is the impact of mid-regional proadrenomedullin to the dosage of loop diuretics in patients with chronic systolic heart failure. I have nothing to declare. This data came from a FAR NHL registry, which is our register of pharmacology and neurohumoral activation in patients with stable systolic chronic heart failure. These data were collected from 7 departments in the Czech Republic with special heart care. Included patients had to be treated for systolic heart failure with non-preserved ejection fractions and had to be stable at least for 1 month with an optimal pharmacotherapy. The primary endpoint in 2-year follow-up was an all-cause mortality, heart transplantation, or left ventricle assist device implantation. A total number of 1,088 patients were included in this register. However, the level of mid-regional proadrenomedullin was available in 569 of them. We have collected medical historical data from the patients, did the physical examinations, and have the biochemical results, including the standard parameters used in the diagnosis of chronic systolic heart failure, as well as the new ones. Adrenomedullin. Adrenomedullin is a vasodilatator peptide hormone. I think you are familiar with already. It's synthesized by endothelial and vascular smooth muscle cells. Its expression can be induced by various stimuli. One of them is the volume overload. So that's the reason why we think it's a good biomarker for patients with heart failure. It circulates in the plasma level in very low concentration in healthy adults. However, it rapidly increases in patients with heart failure. Adrenomedullin itself is unstable and it's not suitable for laboratory measurement. However, it's displayed from a larger precursor peptide and leaving 2 smaller biologically inactive fragments. One of them is mid-regional proadrenomedullin, which is stable enough and it's a reliable surrogate for the measurement which we use for our data. So this is the baseline characteristic of our patient cohort. As I already mentioned, we have included 569 patients with systolic chronic heart failure. Most of the patients were men, the mean age about 65. They've got a normal level of blood pressure and heart rate. The mean ejection fraction was around 31%. The most common etiology of the heart failure was an ischemic one or dilated cardiomyopathy. Because it was stable patients, most of them were classified as NIHA 2 or 3. As I already mentioned, we set the basic biochemical data of all these patients. That means the standard parameters as it is the NT-proBNP, as well as the new one, which is the mid-regional proadrenomedullin. The patients need to be treated with an optimal pharmacotherapy. So as you can see, they were administered by all the basic groups for heart failure. Almost 93% have received beta blockers, diuretics, or furosemide as the most common loop diuretic was administered to about 80% of the patient. And here are already our results in a 2-year follow-up, and we see quite clearly that the patients with high level of mid-regional proadrenomedullin reach the primary endpoint in 2-year follow-up much more often than the patients with the lower level of mid-regional proadrenomedullin, which is displayed in this chart with the probability of the event. Then we set the cutoff value for mid-regional proadrenomedullin to 0.79 to an adequate sensitivity and specificity, and we again see the differences between the patients with the lower and higher level of mid-regional proadrenomedullin, that those with high level has reached the primary endpoint, means death, hospitalization, transplantation, or LVAD implantations much more often than these with lower level. We have also discovered a statistical significant differences in other parameters, like patients with a higher level of mid-regional proadrenomedullin were statistically significant older, classified with a higher NIHA class, more often suffer with comorbidities such as hypertension, atrial fibrillation, diabetes mellitus, more often have a swollen lower limbs, and have worse renal functions. There were no statistical difference in sex, in etiology, and in ejection fraction. Then we related the level of mid-regional proadrenomedullin to the dosage of loop diuretics, the furosemide, and we have discovered that patients taking higher doses of diuretics are having statistically significant higher level of mid-regional proadrenomedullin, which we conclude that may reflect their level of congestion, that these patients are suffering with a higher level of congestion or maybe are not adequately decongested, so they need to receive a higher dosage of loop diuretics, and maybe it might help us also in guiding dietherapy, such as add another diuretic or, for example, use some other method for their treatment. So to conclude, mid-regional proadrenomedullin appears as a predictor of more serious prognosis in 2-year follow-up in patients with systolic chronic heart failure. The detection of mid-regional proadrenomedullin provides prognostic information in addition to an independent of the assessment of NT-proBNP. High level of mid-regional proadrenomedullin combined with increased use of loop diuretics may reflect a level of congestions and may help to detect the patients that are inadequately decongested or are resistant to a diuretic therapy to reevaluate their treatment. Otherwise, low level of mid-regional proadrenomedullin may help identify patients with lower residual congestions whose dose of diuretics appears to be adequate. Thank you for your attention.
So thank you very much for the presentation. You are perfectly in time, and the paper is open for discussion from the audience. Are there questions? Well, so,
Your cut point of 0.79, where did you get that?
It was the best cutoff with the best sensitivity and specificity we got from the statistic.
So you used like an ROC curve or something?
Not really.
Okay.
yeah. Thank you. And could you tell me what are the limitations for usage of this new neurohumoral substance?
Well, I think that the most important limitation for mid-regional proadrenomedullin is that it's still a new biomarker, which is not the part of the standard laboratory parameters. So, for example, in the Czech Republic, we don't have all the laboratories equipped with the special machines or possibilities to set the level of mid-regional proadrenomedullin. So it's still more expensive, more complicated to get this parameter, and it's like, it's not a new NT-proBNP. It's something additional. It's something what adds us another information about the prognosis and about the congestions. So I think that there is still space for this new biomarker, but it wasn't superior to NT-proBNP. It's something additional, something what may just give us some further information about our patients.
You said that there was independent from
yes,
marker of congestion from NT-proBNP, but did you analyze this, if it was an independent predictor?
Yes, we did.
I couldn't see.
I'm sorry, I don't have this data, and this NT-proBNP will be presented by my colleague here, so I don't want to skip his presentation. But the NT-proBNP's prognostic value was superior to the other biomarkers.
So, thank you very much again.